Hello, my name is Andrew Blaikie. I am a consultant ophthalmologist from Scotland. Thank you for giving me the opportunity to speak on Frugal Tech for Sight, the Arclight Project. The Arclight Project is a social enterprise based at the University of St Andrews in Scotland. We enable those working in low-resource settings to equip, train and empower healthcare workers to diagnose and manage eye and ear disease using Frugal Kit. With William J. Williams, an optometrist and frugal engineer, we are addressing the limitations of orthodox diagnostic tools to widen access in resource-poor settings at low cost. The first device I am presenting is the Arclight, a direct ophthalmoscope, anterior segment loop and otoscope. It uses radically different frugal design to that of traditional devices, placing an LED light source directly below the sight hole. This reduces cost and size, as well as allowing it to be solar powered. Around 10 years ago, the Fred Halls Foundation and its medical director at the time, Richard Lemessurier, had the foresight and boldness to offer William a grant of around about €100,000 to develop the Mark I device and scale inexpensive yet equally effective eye care diagnostic tools to the regions of the world most in need. This is analogous to the equally bold and ultimately incredibly successful move by the Fred Halls Foundation to establish intraocular lens production in Nepal in the 1990s. Since the initial grant from the Fred Halls Foundation, the device has evolved and developed within the global health team at the University of St Andrews in Scotland, where William and I both work together. To try to ensure equity of access, there are 4 price bands depending on the Human Development Index of a country. And, despite its low cost, small size and simplified design, many studies have now been published supporting its role as an effective replacement for much more expensive traditional tools. It is not a compromise. This evidence base has recently led the World Health Organization to recommend for the first time that eye screening should be part of the neonatal examination, even in resource-poor settings. We have developed training videos to support implementation for this, as well as all the other functions of the device. This video summarises the content and structure of these materials that can all be found on the Arclight Project website and YouTube channels. Firstly, an overview of the device and how to switch it on, charge it, and what end does what, emphasising there are 2 ends, one an anterior segment loop, and the other a direct ophthalmoscope for examining the optic nerve and retina, as well as performing the fundal reflex test. The teaching videos illustrate exactly what is seen by a user, with normal anatomy and clinical signs annotated. These videos are collected by using the Arclight attached to the camera of a mobile phone, and this is also illustrated in the video. This allows capture of clinical signs for teaching and telemedicine purposes, both in children of the fundal red reflex, as well as in adults for the back of the eye, for looking at the optic disc for signs of glaucoma, or the rest of the retina for signs of diabetic retinopathy. Next, tips on the assessment of the appearance of eyes and observable visual function are described, including fixing and following faces, returning silent smiles, following lights, and engagement with pictures, as well as assessment of squint and the presence of nystagmus. Then the actual technique of performing the fundal reflex test in newborns as well as older children is shown, alluding to the different appearance amongst babies of different degrees of skin pigmentation. The more challenging assessment of newborns is illustrated, describing the different approach needed to that of older children, such as having to open one eye at a time rather than both, and the actual appearance of a neonate, which is different from that of older children. Then normal and abnormal reflex results are shown, including an explanation of the corneal reflection test for the presence of squint, as well as the appearance of cataract, retinoblastoma, corneal scar, squint and refractive error. Finally, and very importantly, we made a video that explains how to deliver a workshop using the range of materials we have developed, including handouts, posters, videos and simulation eyes to ensure effective implementation at the time of distribution. Training the trainers is an essential part of our work, and this video supports capacity development. Local trainers are encouraged to lead with supervision and explain how to use the device with all the tools. Participants then go on to examine each other as well as simulation eyes, which can mimic cataract and retinoblastoma, as well as signs of the posterior segment of the optic nerve and retina. Finally, clinical signs can be illustrated using the device attached to the camera of a mobile phone. And so that's the Arclight direct ophthalmoscope, a cost-effective means to empower healthcare workers of all grades to diagnose all of the major causes of blindness in the world. And that brings me to the second device that we hope to release this year. The development of this has been largely funded by the Overscroft Foundation and the support of John Sanford Smith, a retired ophthalmologist from the UK. The second main device we have developed is an inexpensive binocular indirect ophthalmoscope for retinopathy of prematurity, diabetic retinopathy, and other posterior segment disease diagnosis. The device is very compact and light with a simple elastic headband, and similar to the Arclight, is also solar powered using LEDs as a light source. The IEPD is fixed, but the wide optical entrance can accommodate a wide range of IPDs. There's only one control button which alters the brightness of the light. It's very comfortable and simple to use, and comes with a teaching mirror as well as green filter. We expect this to cost between £400 and £100, depending on the HDI of the country it is being supplied to. A recent comparative study published in Eye found comparable performance to a much more expensive orthodox device. To effectively implement the indirect, we have established interactive workshops. When teaching ROP, the three major components of how to describe and identify threshold ROP are emphasised, with case-based discussions systematically going through each step needed to decide if a baby has threshold disease and needs treatment, or can be reviewed or discharged. Videos of real examinations are then showing, relating zones to the actual view seen using an indirect. We also use edited and annotated time-lapse videos to emphasise zones, as well as the development of plus disease, highlighting this is not a binary sign but a spectrum. Use of simulation eyes is essential to training and assessment. We have pioneered a unique goring technique that turns flat 2D retinal images into 3D hemispherical fundi at ultra low cost. Any images can be printed in the eye, such as non-clinical Leah symbols to EDTRS images for diabetes screening or artist-created realistic ROP signs. The printed images can then be cut out and placed into the body of our simulation eyes and used to train and assess participants. These videos show the wide range of ROP signs that can be emulated in the simulation eyes, creating a highly interactive and engaging workshop. After gaining confidence with the simulation eyes, they can move on to examining each other, and through using our teaching mirror, participants and trainers can confirm what each other are seeing. Finally, after the workshop and with ongoing mentorship, expertise in examining adults as well as babies can be developed. And finally, before I finish, I need to thank the wide range of funding bodies, academic institutions, training schools and NGOs that have supported this work over the past decade. Thank you very much for your interest in our work.